We know that painful joints can stop you in your tracks, and that injuries, tears, sprains, and strains can be concerning and scary. So throughout today's event, we will make sure to share the various ways that you can be seen with the quickest appointments to get you back on the path of living pain-free, which is what it's all about. A little bit about us here at the Cleveland Clinic. We do have over 40 orthopedic convenient locations throughout northeastern Ohio, as well as locations in Florida as well. And while our focus today is on hip and knee joints, please know that we do offer a wide range of treatment for various orthopedic concerns. We have downloadable guides, past recorded videos, and e-newsletters on our website, as well as on today's platform, and I'm going to share with you how to get those. You want to make sure on the right-hand side of your screen to check out the handout section. In there, you'll find some really helpful information, including a lot of the material that was seen on our waiting room that has some great QR codes that you can scan to access those treatment guides, to get you our past videos, to get you signed up for those e-newsletters, and just some really helpful information that can be found there. So please make sure you check that out. And in addition, what we will do is we're going to have some flyouts coming through in case that you really feel a connection with one of our presenters and you'd like to see them, or if you'd like to see any of our caregivers here at the Cleveland Clinic. This is going to be a great way for us to reach out to you. So our offices will call you if you'd like to schedule an appointment. You will see those flyout sections come throughout the presentation today. And then also, if you would like to reach out and you want to just schedule an appointment, you can go to clevelandclinic.org/ortho appointment, and we'll have that information for you. So with all of that being said, I am so excited to just get to the main event here, and we want to begin our event. So I would like to introduce you to Dr. John McLaughlin. Dr. McLaughlin received his medical degree from the University of Pikeville, Kentucky College of Osteopathic Medicine, graduating in the top 10 of his class. He went on to complete an orthopedic surgery residency here at the Cleveland Clinic. He then obtained advanced training in adult reconstructive surgery and total joint surgery by completing the James A. Dixon Fellowship here at the Cleveland Clinic. His specialty interests include hip and knee replacement, hip resurfacing, revision of painful or failed total joint replacements, complex hip and knee problems in the elderly, and long bone fracture care. Wow, what a wonderful bio, and what a great honor to have you here, Dr. McLaughlin, and I'm going to send it right over to you.
All right, Deanna, thanks for the kind words, and I'd like to welcome everybody for joining us today. I hope that this is an opportunity for you to learn education. That's the most important part of this. Patients that are well-versed in their care, they do better. So my part of this is to go through hip replacement. I have no really relevant disclosures. These can be found, but we're not going to be really talking about particular types of implants or anything like that. This is more directed at patient education. Education of the patient is so important because it gives them the opportunity to know where we start with, what they can expect on the day of surgery, and specifically after surgery. Knowing those expectations, knowing the road ahead is really important. We talk about why we do joint replacements. A lot of people think it's for pain relief, which it is, but it's to restore the patient's function and their physical capacity and really get them back to activities that they enjoy doing, and hopefully forgetting that they ever went through the surgery. And then also preparing them for that journey, as I talked about. Really educating before, during, and after goes a long way. So before surgery, giving explanations. Why am I experiencing the pain that I am? Why am I not able to keep up with my husband or wife or whoever with walking? Why am I not able to keep up with my grandkids? What's going on? Why is this leg different? Having a good definition and understanding of arthritis goes a long way. So what do we see on x-ray when you come in and tell me that your hip is bothering you? The first thing that we see is joint space narrowing. If you look to the top of your left screen, you can see an RT. So that's the right side of the patient. And obviously the other side is the left. The left hip looks okay. We don't see a lot of joint space narrowing, but that right hip looks a lot different. We can see that the halo or the separation of the two bones has gone. So really what we're thinking and what we're seeing is really bone on bone arthritis, is that cartilage has eroded. So cartilage is covering the ends of our bones. And so what keeps the bones apart, it's relatively frictionless. It's nice and smooth. So when that wears away, we see those bones contact each other, and that's what's painful for you guys. We also see changes in the bone itself because it's stressed differently. Again, the left side and the right side. And the right side, we see that the bone is wider or it's sclerotic, right? Because normally we bear weight in the front and back of the hip. As that hip starts to wear out, we start to bear weight on the top, and the stress on the bone makes a change. The other things that we see is we see extra bone formation. So the thought is that the body's response is to send that joint space or send that joint surface over a larger area to decrease the amount of symptoms that it's having. Deanna, I lost my slides. Maybe, there we go. Okay, sorry about that. So decreasing or increasing that amount of space over a larger area, but we know that doesn't work. So you get limited range of motion with this extra bone that's formed. Again, the left side's a lot different than the right. The last thing we see is sometimes cystic changes. So we know as that cartilage erodes on that body or on that joint, the fluid that's within the joint can be pressed within the bone, and you get cyst formation. When we see the cyst formation, we know that the arthritis has been there for a long time. Again, the left hip with that blue arrow on the side looks a lot different than the patient's right hip, which is relatively symptom-free, and the radiographs look very normal. Arthritis is something that we're seeing a lot more of. By 2030, we expect 65 million adults to have a true diagnosis of arthritis. The challenges that we're seeing is one is that we're living longer. When Social Security was initiated, the average age of a patient that would pass away at that time was about 55. Now it's about 78 years old. So we're stressing our joints over a longer period of time, especially as we age, and that's going to wear out that joint over time. The other thing that we're dealing with is the challenge of obesity. This puts a biomechanical stress on there. So we'll talk about joint reactive forces, or the force that's going across the joint, but also physiological. Right? We know that the cartilage has response to obesity in terms of inflammation and the complications that happen with that, or the early degrading of the cartilage itself, putting the patient at an elevated risk for hip and knee replacement, and also the challenges from a postoperative standpoint with obesity, and sometimes the challenges that we face and what we can do to optimize and get through those. Total amount of joint replacements is going up as we see more patients are aging, more patients with obesity, things like that. In 2005, we are about 500,000. 2030, we're over 3 million projected joint replacements. So it's really important that we continue to educate ourselves on where we're at and what we're doing. Why are there so many joint replacements? Also because it's a surgery that works. Hip and knee replacements have very high satisfaction rates, and that the patients find an increase in their function. They find a decrease in their pain. Now, patients come in all shapes and sizes, all different ages. So if you're a less active patient, that pain relief is a big deal. Living in pain is a very difficult process. It affects our mind much more than the joint that it affects. And stability. My hip hurts to where I don't feel stable when I walk. It feels like it's going to give out. What used to be a smooth surface is now turned to a roughened surface, as you saw those x-rays, and there's apprehension with your gait. And those are all expectations that we see. And then the less active patients, the speed of recovery. It's a significant change to your lifestyle, even just a couple of weeks down the line, that wow, the benefit of the joint replacement is a lot different. There's also benefit in the active patient, resuming activities, things that I used to like to do. I used to walk in the metro parks for 3 miles. Now I'm lucky if I can walk down my driveway. Again, the speed of recovery is good. And then when I walk, I can't keep up. I'm limping. People ask me, am I okay? Those things, the goal, and I'll tell you this, if I see an office, is we do your surgery. is the goal is to walk in the community and no one would ever know that you had surgery. And so those are big changes in the patient's life. The implants themselves, the longevity. So in 2005, and that's the terms of the age is about 65 is the average age of a joint replacement. So we expected it to last 15 to 20 years. So it gets you through what the average age of expectancy would be. But as we've gone further and further, what we're seeing is those joint replacements are lasting even longer, and it's really coming from the point of the implants or the piece of plastic or the bearing surface. That's where we've seen the most advances over time. So we don't have the final data because we haven't had it out as long, but what used to be 15, 20 years is now expected 25, 30 years. Obviously, complications can happen, but the expectancy is a lot longer than it used to be. The force across the hip, we'll kind of go over this. We know that the body weight puts a force. We know that our muscles put a force. And it's really this seesaw idea where our hip is right in the middle. And those forces are acting both on the inside and outside. And we got to balance those. So what does the anatomy look like in the hip? So we talk about a ball and socket. So this is your acetabulum or your pelvis. This is the socket portion. That white portion is cartilage that's normal. That pinkish kind of outline around there is what's called your labrum. Those have functions, and that's how your hip moves in the native joint. It's also surrounded by a balloon of tissue or ligaments. We know that ligaments connect bones to bones. So we see that these three ligaments surround that hip. And so when we do surgery, we go through the muscles, we go through these ligaments, and the repairs afterwards are just as important as the replacements themselves. This is the main muscle, or two main muscles that we talk about are our gluteus medius and our gluteus minimus. These are the muscles that pull that hip up into the socket, keeping it stable and keeping our pelvis stable as we walk. As I'll kind of show you some examples. Here's a way that those muscles work. They either move our leg out to the side or they move our body down towards the hip. These aren't really normal motions. What the more normal motion is when we get up on one leg when we walk briefly, it balances our pelvis, right? So that this person is standing on their left leg and they're balanced, not falling either way. We can see when that muscle isn't strong, the patients will tilt away from it. So that can be a problem. But also when our joint hurts, we want to move our weight more over that joint to decrease that joint reactive force. And I'll go through the ways we do that. But the overall idea is those muscles pulling that hip into the socket. So sometimes we want that for stability purposes, but when our hip is arthritic, we try to avoid that and it causes us to limp. So things that we can do in terms of decreasing those joint reactive forces. One of them is weight loss. So in terms of the body weight, we see the one side of the seesaw, and then we see the abductor or the pull of the muscle on the outside portion. So even just a little bit of body weight causes that muscle to have to pull less, thus a less joint reactive force and hopefully a little bit less symptomatic within the joint itself. An assistive device in this example is a cane. So this gentleman's hip is, we'll say his left side is affected. So we put that cane in the contralateral or opposite hand. What does that do? It takes a little bit of our body weight and distributes it through the cane in our hand, but it also puts that muscle at the longest tension, increasing the ability to pull and having it not need as much pull, thus not pulling that hip as much into the socket. So that's why sometimes a cane or assisted device is beneficial to decrease pain and also increase stability. We got these crazy different formulas for figuring this out, but I really, got Doc Brown's, this is like a Doc Brown equation that I reference sometimes, but more importantly, just thinking about the seesaw, really balancing the inside portion of that seesaw and the outside is what we're doing around the hip. And these are a lot of the principles that we think about when we're doing the surgery. Putting the implants in the appropriate position is vital, both for the stability and the initial time after surgery, but also the longevity in making those implants last that 25, 30 years that we talk about. So how do we do that is really restoring the position of the hip in what it's supposed to be. A lot of times patients have affected this because of their bone wear, cartilage, and things where we've seen some of those x-rays that are pretty significant. So as a surgeon, it's my responsibility to put those muscles at the appropriate tension, to move that hip into the appropriate position in terms of length and offset to optimize the position of your hip and improve the function of it. We also think about things that affect those muscles. So those muscles have a vital role of keeping stability, but some patients have had a stroke in their history. They might have MS, Parkinson's. They might be a fall risk. All of those things have to be taken into consideration in terms of planning for surgery. The more we plan before surgery, the better outcome that we can have afterwards. In the non-operative, I imagine most people on the conversation have not gone through surgery, maybe have one side, but just it's important to understand what we can do. A good surgeon will tell you what we can do prior to surgery to optimize the outcome, but also try to delay that surgery as long as possible. So some of the things from a non-operative standpoint that we look at is we know that NSAID therapy or like Advil, Aleve type medications on a short-term basis either can take that hip that was doing well, maybe a little bit of step funny and I got some pain, maybe it can get us back to the baseline, or it can manage my symptoms, allowing me what I need to do on a short-term basis, knowing that maybe a hip replacement is in my future, but right now is not the time. So we know that NSAIDs or ibuprofen, anti-inflammatory like medications do have a benefit for the patient. Steroid injections are not something that's going to solve the problem, right? What we use most commonly is for both therapeutic, so we want to make the hip feel better so the patient is less symptomatic, but also a diagnostic component too. So if we're having issues with maybe the back, maybe the hip, how much of my pain is coming from a particular location? The steroid injection will give us a lot of that information. Doc, the pain I had in my the front of my groin, pain that radiated down my thigh, that's gone. But the buttock pain, the low back pain that I had is not gone. Again, having the patient involved in the care, setting those expectations are vital to the outcome. Physical therapy. So patients with minimal to moderate degenerative changes, really a little bit different than the x-rays I showed you. We know that strengthening the patient, improving range of motion, stretching, things like that, those have a benefit. Working on good gait mechanics, proprioception, or stability with the gait do have a role to helping the patient improve their function and getting around in the community. Not a lot of role for gel injections. This is more something that we do in the knee, but not a lot of role in the hip itself. So there's different types of patients that I see. One is they've been referred, obviously, that they've been down the road. Surgery is something that I know. I've had a long discussion. I've met with my primary care doctor. I've either met with a PA, nurse to some instances, and it's really the final time with the surgeon. But other times is information, and it's exactly what we're talking about. I don't know what the problem is. I don't know where to go from here. I'm scared of surgery. I didn't know my joint was that bad. Those are all normal and real thoughts, and it's really important to know that. Things I'll tell the patient, they'll ask, how do I know it's time, doc? And one of the things that we talk about is, does the pain wake you up at night? Does it prevent you from doing reasonable activities? If you're a marathon runner and you're struggling the last couple of miles, maybe that's a little bit different than, I'm struggling getting around in my house. I want to go to the store. I want to go to a movie. I want to go to church. Those things that are really limiting reasonable activities, maybe that conversation is time. And the other part is stability, as we talked about. I don't feel confident in my hip. It feels like it gives out. Those are concerns that maybe a joint replacement is in the near future. We know the things that we do before surgery outside of orthopedics really have an importance for the outcome. We look at the nutritional status. So really, we look at different lab results and protein levels because we know that these affect the patient's outcome in terms of infection, healing of the wound, overall just survival of the surgery itself. A good nutritious diet before surgery and optimizing that is only to our benefit afterwards. Diabetic management, right? We can't cure diabetes, but we can manage it. We know that the patients that are uncontrolled in their diabetes, risk of infection, wound healing, stroke, mortality, and countless other things, those risks are real. And we have to modify those risks as best as possible, right? So some risk factors that we have are not modifiable, but controlling our diabetes is very modifiable and very beneficial after the surgery. Anemia, or our hemoglobin in the blood, we look at this and we want to make sure that the blood is appropriate, carrying that oxygen to that new hip and that incision that we've made. We want to make sure that that healing is appropriate, but also for our heart, our kidneys, lungs, all of those things are vital to the recovery and the stress that you're going to put on them. So we want to make sure that our blood levels are appropriate. During surgery, our transfusion rate is significantly lower than it used to be. What we would think in a total knee replacement, receiving a transfusion out of 11 to 20%, hip replacement 16 to 37% of the time has gone down to about a percentage or even under 1% with the use of what we call tranexamic acid. It's really a medication that prevents the breakdown of clot. It has been absolutely revolutionary in surgery to decrease the risk of bleeding after surgery and specifically decrease that risk of transfusion. A lot of topic and a common topic now is the approach. The different approaches to the hip. There's 4 main approaches: an anterior lateral, lateral, and posterior. And what we found is there's benefits and there's risk to each of these approaches. And your surgeon will go through with you explaining what are the specific risks to the approach, what are the significant benefits, and what are the significant modifications, like just initial time after surgery, that I'll have to make. Most importantly is how your surgery is done. We know that all of these are looked at. We're looking to give you one operation on your hip that's going to last you 25, 30 years. That's the goal. What is a hip replacement? What does it look like? So on the left of your screen, you can see an arthritic hip. Obviously, this is kind of a cartoonish model, but you get the idea. So on the femur side or your thigh side, that implant goes inside of the bone. Commonly, we'll either cement it or the bone will grow into the implant. We'll go over that. On the socket portion, we expand that socket and we put an implant into there. So what we think of as that hemicircle area, we expand that a little bit. The cup goes in and the bone will bind to that cup over time. If you think about if you broke your arm, we put it in a cast. How long does it take for the bone to heal? 6 to 8 weeks. That's what we're waiting with this. Really, for the bone to grow into it, again, lasting 25, 30 years. Here you can see just how those implants go in and just an idea, rough idea of what a hip replacement is. And there's a final result there. So we talked about the different types of implants, but what's most important is to know how that implant stays in my body. This is an example of what we call press fit. So these implants go in very tightly into the bone as we prepare the bone for that, and then over time the bone will grow into it. We look at the different parts of the implants that we're using. We're looking at the porosity of them, the sizes of those pores. We're looking at the gaps between the bone and the metal. We also want to make sure that we're preventing any type of micro motion at that time after surgery. We want to get that implant in a position that we want less than a human hair type motion for that bone to grow into the implant. Sometimes that's not possible. As we age, our bones can become less in terms of quality. Maybe osteoporosis or osteopenia has been a diagnosis, maybe the shape of the bone, possible radiation of the bone over time. those implants will be cemented in position. Those implants, as we know, will do just as well. It's really looking at that bone before and during surgery and picking what is best for how to put these implants into the positions that are necessary. There's different types of cement techniques, but overall, it's really getting a good binding of that implant to the surrounding bone if we're using cement. We look at the different bearing surfaces. I talked about what is improved. Why do we see the implants lasting longer? It's for the piece of plastic or the parts that are actually touching in the joint itself. Most commonly is a ceramic ball, and that is on a polyethylene liner. And really how those liners are made, and they have the less wear rates, less particles, the sizes of the particles are different than they used to be. All of those are advantages for making the hip last longer. We also look at how the patient is shaped. What we used to think is if we put the implant in this particular position, it's going to be great. Well, as we've educated ourselves over time, we know that people are different. They're shaped different. They have different angles for their body. Their spines have different angles. And so we take those things into consideration. So we look at things of how the pelvis is tilted. Is it tilted to the front? Is it tilted to the back? The rotation of the pelvis. Has the patient had some type of lumbar surgery where their spine moves differently, thus their pelvis moves differently, and maybe the what we call standard hip position is not going to be what's best for them. This is just how patients move through the standing and seated positions. We look at the patients that are at a higher risk for surgery in terms of the hip stability afterwards, and what can we do before and during surgery to lower those risks. So things that we use during surgery now are robots. And so robots have the accuracy and the precision that we look for, right? So if someone has a particular hip position that their implant should go into, then that's what we're going to try to do from a robotic standpoint. We look at imaging beforehand. So we look at the bone of the patient, we look at the shapes, sizes, the rotations, and get a plan of what can be best. Then in surgery, we'll map the bone to make sure that we have a communication with what we saw before surgery on imaging and what we're seeing in the surgery now. Then implanting those implants into those positions, and the importance of seeing that this is where it needed to be, and this is where it is. Really, other things in terms of stability, leg length offset really help from a robotic standpoint. Here are some x-rays from some recent patients that we talked about. Again, if we're looking at the x-ray on our left side, the hip to our left, I know it gets confusing, but it's just opposite of, when you're looking at someone. But we can see that the hip on our right, or the replaced hip there, looks a lot different. That bone has been worn down. It's not round anymore. It's a different shape. The patient has lost a lot of their length of their hip. And when we do that, when we restore that, we want to move that hip center back to where it's supposed to, put those implants in the right position, restore that leg length of what that hip's supposed to be. Here's a lady that had her hip fixed at an outside facility after a traumatic fall. Unfortunately, with this fix, that the femoral head did not take. It did not. There was not a union of the bone, and then also the femoral head went on to dying, or avascular necrosis. And so this is a different type of hip implant, but just as important, of restoring the position of that hip in terms of the muscles, tendons, ligaments, all of those things to optimize that patient's recovery. This is a lady that I had from Indiana that was affected by polio. Her area did not have vaccines. It was a very long time ago. And really, this is a much different case than a standard hip replacement. And so having, if you look at those two hips, they just look a lot different, right? The effects of polio. And so the shape, the sizes, the rotation, all of those things have to be taken into consideration to get her an implant that lasts, again, 25, 30 years is what we're hopeful. This is a really interesting case for a gentleman that had adult hip dysplasia, or his hip on our left side did not grow the normal way. And we can see that he has formed a whole new area of this pelvis. So his hip was articulating or moving on an area that isn't even his socket. We can see how that left leg is considerably shortened. We can see the bone quality is different. We can see the cystic changes. All those things we look at are vastly different. And so we can see that when we do that hip replacement, we're really restoring or bringing that hip down to the position that's supposed to be, restoring that leg length, finding the position and the implants that are best for the patient to move forward with. After surgery, we want to make sure that the patient's pain is controlled, knowing both from a cognitive standpoint, but also the different things that we do during surgery to decrease a patient's pain for their comfort, and then also being able to do the recovery afterwards is really important. So things that we look at is we look at education, exactly what we're doing now in terms of the patient's pain perception and what the brain is thinking for before, during, and after surgery, giving medications before surgery, as in the preoperative area, spinal anesthetic and the benefits to mobilizing early after surgery, and then also nerve blocks. And all of these things are a lot different than they used to be. Is it a painless operation? Absolutely not. Is it a lot less pain than it used to be with earlier mobilization? Absolutely. So again, decreasing opiate intake, we know nausea, constipation, the cognitive impairment, respiratory, blood pressure, all of those things can be affected by opiates and long-term opiate use, which we're definitely trying to avoid in the troubles that we've run into, as everyone knows. Early mobilization, limiting vertigo, nausea, vomiting, severe pain on the day of surgery, returning the patient to their normal environment so they can heal at home. Patients like to heal at home. We know that home discharge decreases the risk of overall complication, readmission, any kind of just complication really, and the satisfaction of the patient is a lot higher when we're able to get them home versus going to a skilled nursing facility or a long stay in the hospital. And then the benefits of length of stay. You're there because your hip is hurt. You're having a surgery. You're not there because you're sick. We want to get you in the hospital, do a good surgery, and when it's appropriate, then we discharge you. And a lot of things go into doing that. We'll take some questions at the end, but again, thanks for joining us, and I'm looking forward to further discussion.
Thank you so much. We really appreciate that presentation. Absolutely wonderful. And we're going to see Dr. McLaughlin momentarily after our next presentation. So thank you very much. It is my pleasure to introduce everyone to Dr. Michael Erossy. Dr. Erossy grew up on the west side of Cleveland and went on to receive his medical degree from Northeast Ohio Medical University College of Medicine. He completed his residency here at the Cleveland Clinic and then a fellowship at New England Baptist Hospital in Boston before coming back home to the Cleveland Clinic. Currently, he is specializing in primary knee replacements, vision surgery, robotics, as well as direct and total hip replacements. Dr. Erossy, we're sending it off to you.
Thank you so much. Appreciate the introduction. Just to reiterate, a little bit, exactly. Just about me. I grew up here in Cleveland, local guy. Went to school in Columbus, out near Akron, and then Boston for my fellowship training. Been back here at Cleveland Clinic since 2024, and operate kind of all around the city. So, kind of as Dr. McLaughlin emphasized. I think really education and teaching patients about what's going on with their joints, whether it's hip or knee, and having you as the patient, really take and take charge of your own education and knowledge of what's going on is super important. And I think it's our job as surgeons to spend some time and educate people about what's going on. Here's your x-rays, here's your physical exam, and what are the treatment options, and being knowledgeable about your condition and what are the options and the risks and the benefits and all that stuff, I think is super, super important. And invaluable to help you make the best decision for yourself. I say all the time that, we don't treat x-rays, we treat patients, and we treat you, with the problem. And so there's, a lot that goes into that sort of shared decision-making. Attending and listening to something like this, I think is awesome. So moving on from the hip to the knee, a little bit of a different joint, but one that, most people have. Most people have two knees. Complex hinge joint with a large, rotational component to it. Moves in kind of multiple different planes as you're going from your knee fully straight to bending it. Necessary for ambulation, stairs, any kind of activity, running, jumping, squatting, pretty much all movements of the lower extremity. So super important, pretty complex anatomy. And this picture on the left here is just what a normal knee x-ray might look like. You have, nice maintained joint spaces on both the medial or the inside and the lateral or the outside compartments of your knee, as well as the patellofemoral compartment, or the one underneath your kneecap, where your kneecap has, the thickest cartilage in your body, where that nice smooth chondral surface, the cartilage surface, can glide in that groove on the femur bone. Lots of ligaments, your tendons attaching around and to the knee joint itself that can be injured with any sort of injury, or a more of a degenerative process like in osteoarthritis or rheumatoid arthritis, any kind of other inflammatory arthritic process in the knee. The meniscus, another important structure that is like a bumper. There are two C-shaped rings of cartilage that live inside your knee. One C is on the inside of the knee, one C is on the outside of the knee, and they're shock absorbers. These are super important to distribute the contact stress of your knee when you're ambulating, running, jumping, etc., doing all those things. So if you're an athlete or a weekend warrior and you have an injury or something, and you tear that meniscus, that can drastically change the way that your knee functions and the mechanics of your knee. That can contribute to arthritis down the line. Again, just another view of the knee joint itself: femur bone, your kneecap, and your tibia bone, and the extensor mechanism, which is your quadriceps tendon, the patella, the patellar tendon, which attaches down to the tibia. So just an example of, again, what a normal knee x-ray looks like, and then an x-ray with pretty severe arthritis. You have, just like in the hip, narrowing of that normal joint space that you see on the left side in the normal knee joint. That's not real space, that's cartilage that you just don't see on the x-ray. In cases of bad arthritis, that cartilage gets worn down, the joint space gets narrowed, which we can appreciate on the x-rays. And the other changes that you might see are this bone getting, this whitish or really hard sclerotic appearance to it, as well as bone spurs or osteophytes. In a state like this, the knee is very irritated and inflamed, and part of the joint's response to that is to make more bone. It forms these little bone spurs or osteophytes in an attempt to make the joint stiff, and it's part of this whole kind of inflammatory reaction that goes on in the setting of bad arthritis. And again, just very simple. What is arthritis? It's this degenerative process that happens over time. There's multiple different reasons that it can happen, but the end result is irreversible damage to the articular surface or the cartilage within the knee joint. It can affect any or all of those compartments that I talked about: the medial or the inside compartment, lateral or outside, and then the patellofemoral or the kneecap compartment. So joint replacement, as Dr. McLaughlin said, is, we're taking out the worn out joint and essentially filling it with metal and plastic, to put it simply. For the knee, it's typically metal on the femur bone, metal on the tibia, with a plastic insert that goes in between. And if you have severe arthritis underneath your kneecap, we replace that as well with typically a plastic button that goes on the undersurface. So now there's no bone-on-bone arthritis. The bone ends aren't rubbing on each other, which is what causes pain, and what the bone nerve endings are telling your brain is pain. So again, these are, metal and plastic. It's a high molecular weight polyethylene, which is a really fancy plastic with really excellent wear properties, a very low friction surface, mimicking that of your normal cartilage that's normally bathed with synovial fluid. So again, taking out the arthritis and filling it with metal and plastic. As the arthritis progresses, we can develop different deformities about the knee. So a bow-legged appearance is called varus, or a knock-kneed appearance is called valgus. And so those are two different categories or types of deformity from arthritis, and we kind of have different ways about treating and balancing those when we do a joint replacement. So for knees, you have total knee replacements as well as partial knees, and I'll get into that a little bit more just as far as treatment options. As far as making the diagnosis of arthritis, we use the history, the physical exam, which can show a decreased range of motion, obviously pain to certain aspects of the knee, an antalgic or a limping gait, pain when you push on certain areas. You can get these intermittent swellings or effusions, and then that deformity again, like we talked about. So again, more example of what you might see in a severely arthritic knee. So this is a patient's knee x-ray, where again you see that normal joint space that we had on that first x-ray is really narrowed. It's starting to get a little bit of that bow-legged or varus type appearance to it. You have bone spur formation both on the femur and the tibia, and you can get these little bony cysts that form again as part of that inflammatory process that happens in the joint. So treatment options, this is a arthroplasty or a joint replacement kind of talk. So that's, kind of our focus today, but surgery is a last resort. We don't want to operate on you unless you need it, right? It should be when all of the conservative options, all of the non-surgical options have failed, because there's obvious risks with doing a major joint replacement surgery, which is what hip and knee replacements are. We start with simple conservative options. Tylenol is an over-the-counter anti-inflammatory, Motrin or other NSAID medications. If you're able to take those, there's different things we can do with diet, keeping your diabetes well under control. Voltaren gel is a topical cream. Physical therapy, like Dr. McLaughlin talked about, ice, heat, cane, walker, some directed land physical therapy. Aquatic therapy, getting people in the water, walking in warm water, doing some exercises where you take gravity out of it, that can make people feel a lot better. Typically, it's not one thing that is just a magical thing that makes this go away. If you've been dealing with progressive arthritis in your knee for months, if not years, it's a multifactorial, multimodal kind of treatment regimen that we all try first before we get into surgery. Cortisone injections, which is a strong steroid with some numbing medicine in it, is an option, as well as gel or hyaluronic acid injections. Both of those, really, the goal is to just reduce the inflammation in the joint. There's no magic to it, or it's not some magic bullet, but some people with mild to moderate arthritis or even severe can get an injection and really gives them excellent relief for a long period of time. It is a Band-Aid in the sense that, they don't repair the damage that's been done in terms of growing cartilage back or, really lubricating the joint. Really, the whole goal is to reduce the inflammation in the joint, which should help with the pain. In certain types of arthritis, some braces, like a medial offloader brace, is something that can help. And then there's different nerve procedures, like geniculate nerve block procedures, iovera, different options there as well that can provide some relief. Surgery for end-stage knee arthritis is a total knee replacement. Partial knees, which we'll talk about a little bit more, but if you have really isolated disease to one compartment of the knee, there are options to replace just that one compartment. There's certain criteria that we have from a patient selection and really an anatomy standpoint that make one a good candidate for a partial knee. But those are things to talk about with your surgeon. And then osteotomies, is maybe somewhat of a historical option. Not as many of them are done anymore, but like a medial tibial osteotomy to correct it in anatomical deformity. Those are still potential options. What's the goal of the joint replacement surgery? Why do we do it? It's for pain control. Again, as Dr. McLaughlin talked about, improving your function, quality of life, getting you back to doing whatever it is that you're doing, that you're not doing because of the pain that you're experiencing from the arthritis. Work, kids, grandkids, whatever that kind of stuff is, that's the whole goal. That's it. So just as an example, what one looks like on x-ray, we take that arthritic knee that we have that has failed all of the conservative treatment options, and the patient feels like they can't live with it. Doc, what can we do? Well, you can do a total knee replacement, which again, metal on the femur bone, all the white is metal, metal on the femur, metal on the tibia, and there's a plastic insert in between. And kind of what you don't see is the plastic button underneath the patella there. So again, knee replacement is an incredible surgery. Same with total hip replacements; they work extremely well. But there is kind of a historical, relatively highly large percentage of patients that still have some problems with their knee after a while. After they recover, 10 or 15% of people still have some aches and pains, and it still bothers them with certain activity, or if they overdo it one day, they really feel it. And so we're trying to push the needle and get that number lower and lower, and we'll talk about some of the ways that we're kind of doing that. And I do think robotics is a major part of that. There's roughly 600,000 of these done every year in the US, so extremely common. We do a ton of them, obviously, here at the Cleveland Clinic, but it is certainly not without risk. That, again, it's our job as surgeons to make sure that you are aware of all of those and understand those when you're thinking about doing a big surgery like this. These knees with modern techniques, modern implants, should last you a very long time. The goal is 25 to 30 years. And, for a patient in their 70s or 80s, that, the implant should outlive them. Again, low complication rates, but they're not zero. Some of the major areas that we've made advancements in is, kind of, as Dr. McLaughlin again talked about, is pain control and a multimodal pain regimen leading up to the surgery, even beforehand and afterwards. Our rehab protocols are significantly better. Our therapists, have a better understanding of our goal from the surgery and how to best rehab these patients. Medications, dosing pre-op. Many, if not all, most of us, all of us here, use some sort of periarticular pain cocktail. There's different kinds and whatnot, but again, the goal is to reduce the inflammation and pain sensation after surgery. Spinal anesthesia, so we numb up your back, the anesthesiologists do, and put some medication in your spinal area, basically like an epidural. It makes your legs numb. You can't use them for a couple hours. It really helps with postoperative pain, lower blood loss, helps us do the surgery safer and easier. That has really made a huge change. So when do you do this? When do you consider surgery? Again, you do this when you feel like you can't live with it anymore, despite all of the conservative things that we're trying. And it's kind of an active discussion between you, being an informed patient, and us as the surgeon, to help patients figure out when that is for them. When your family activity is limited, when you can't work, when you can't take care of yourself or others that depend on you, when all of your activities of daily living are impaired, when you can't go on walk with your spouse, when you can't, this is a function restoring procedure. That's the goal. So this is a joint replacement or an arthroplasty talk. So, sports medicine guys do a lot of knee and hip arthroscopy with little cameras and poke holes. That's really not our forte. But in certain patients, again, with minimal arthritis that have a bad meniscus tear, or other pathology to like the ligaments around the knee, that can be a very viable option and can, prevent the development of arthritis and, hopefully prevent somebody from needing a knee replacement down the line. But in a patient with arthritis already, doing a knee scope on them does not really provide much benefit. Talked a little bit about partial knee replacements before. This is, again, a solution for one compartment disease with minimal deformity to the knee and the other adjacent compartments. This is an example of a medial or inside unicompartmental knee replacement. So this patient had isolated disease to the medial compartment, can be a very viable and good solution, particularly for younger patients with isolated medial compartment disease. Their ligaments have to be intact, and there's some criteria that we have to make patients a good candidate for it. But the risk of this is that over time, over years, you can develop arthritis in the other compartments of the knee, which is a low risk, but also not zero. So who gets total knees? Patients with end-stage knee osteoarthritis that have failed all conservative treatments. And again, they're in pain all the time, and they can't deal with this anymore, despite all of the things that we, kind of talked about treatment-wise. Getting patients medically optimized is super important. This is, elective surgery in the sense that, arthritis won't kill you, not like a heart attack or a stroke or something like that will. We typically have time to work with patients and to get them ready and as safe as possible for surgery. That's why we have cutoffs for patients getting a joint replacement. So BMI is super important. That's been shown over and over in our orthopedic literature to increase risk of infection and complications after joint replacement in general. Having patients' diabetes well controlled, smoking cessation, nutritional optimization, and being on a high protein diet, protein shakes, allowing your wound to heal, maximizing your immune function. If you're on any kind of chemotherapeutic medication or medications for rheumatoid arthritis, some of those can really affect wound healing and increase infection rates. So, there's a lot that goes into being optimized for surgery. What does this actual knee surgery look like? Well, it's hopefully outpatient surgery, so you're going home that same day. Big believer that again, as Dr. McLaughlin talked about, is hugely important and is really helping patients. We want people to get home. It's typically better for them. People do better at home, and they tend to recover better there. That takes a lot of education up front and setup and having medications and therapy and all these things on the front end, but I do think that makes a big difference in your recovery. Surgery time, typically about an hour. To 2 hours, just kind of depending. Recovery from a joint replacement, in my mind, is a full year to recover from this. You're feeling a lot better, after 4 to 6 weeks. You're feeling really good, typically after 3 to 4 months. But you can see recovery, still making small strides even up to the first year after the surgery. We get you up and moving right after the surgery. Typically, unless there's any issues, you're full weight bearing on it. You're bending and moving that knee right away. We're icing the knee. Typically, you have some kind of dressing that stays on for about a week on the front of your knee, and then you are taking that off at home. Getting into some of the advancements from a technical side of things, the different implant styles have changed over time as the implant manufacturers have trialed and errored in lots of different ways. The standard knee replacement is a cemented knee that uses a polymethyl methacrylate bone cement. It essentially functions as a grout. It holds the metal to the bone. That's all it does. That's been highly successful. It gives you excellent longevity and survivorship to the implants. Has been historically the gold standard. There's pros and cons to that, of course. The grout will eventually loosen. It's just a sort of a race against time. Hopefully that is 25 to 30 plus years, but it can loosen over time. The advent of cementless or press fit implants is a little bit of a different design. The backside of the implants have a porous metal surface to them that's very rough and sticky in terms of getting the implant to bite into the bone. Over time, the little bone cells will migrate into those microscopic pores and grow into the metal. The goal is that once that bony ingrowth process happens over really, the first months to 6 months to a year after the surgery, that process kind of evolves. Those implants should never loosen. The bone is stuck in there. It's a biologic fixation that should theoretically never loosen. We need that ingrowth process to happen, and that relies on good bony contact from the implant to the bone. And one of the ways to get that and have super accurate cuts is robotics. Again, multimodal pain control after the surgery, spinal. The anesthesia guys are really good with doing nerve blocks for us. We all do local pain cocktail injections, getting patients up and moving quickly, same day surgery, going home, where you're not sitting in a hospital bed, kind of, getting stuck there. We need people to get up and move after the surgery. That is super important. Prevents blood clots. Their pain is better. These are all good things. Robotics is probably the biggest advancement in knee replacement surgery in the last 20 years. The surgery is not performed by a robot. There's different styles of robotic platforms as robotic assisted surgery. Some of them rely on a CT scan. Some are X-ray based. where you're sort of picking the bony anatomy points during the case. Whatever platform it is allows you significantly greater surgical precision than just your eyeballs. We think we're really good at, here, degree here, degree there. Really, we're not that great at it. At least I'm not. So using a robotic platform allows us to be very accurate with the cuts, to balance the knee appropriately, the gaps in when the knee is straight versus bent, allowing us to put the components exactly where we want them to sort of recreate the patient's natural anatomy, again, which is different for every patient. All of that lets us dissect the soft tissues a lot less, helps with pain afterwards. You're not exposing the knee quite as much. And the accurate cuts that the robotic assistance provides does help us with the fit of the implants if we're trying to do press fit components. Again, multiple different robotic platforms, lots of different implant vendors that are out there, all of which are pushing the needle on this to make these better and better every day. For me, my knee practice is a majority of robotic knees. There's different, again, robotic platforms that are available, some CT-based or CAT scan-based, some are not. And I'm splitting my, cemented versus cement-less knees. Again, that's tailored based on the patient age, their medical comorbidities, the bone quality, the accuracy of those bony cuts, all of which I think factors into that decision. And that's a discussion to be had with your surgeon who's going to do your joint replacement. And again, I'm a big believer in outpatient joints, getting patients home the same day. And the key to that is patient education, talking to people ahead of time, knowing what to expect, knowing what the expectations are, helping them, again, have their meds and the therapy and all this stuff arranged ahead of time, makes for a very smooth day of surgery and then going home and recovering at home and starting rehab. That's all I got. It's just a picture of me and my team starting to do some outpatient total joint replacements at a true ambulatory surgery center in Lorraine with one of the robotic platforms. So just kind of pushing the needle on that. So thank you very much. I appreciate your attention.
Thank you so much. That was wonderful. I feel so just very honored to have both of you here with us. And again, fantastic presentations. I think that there's a lot of tremendous information that we received. And I do want to start our Q&A, although it's going to be difficult because you guys answered a lot of the questions that we had posed upon registration. Our audience had offered and submitted some really fantastic questions, which I know both of our presenters had received as well. But we do want to get to some of the questions that were asked, and I will pose those to both of you, and we can kind of go from there. But the first question that I do want to ask, and I'm going to send it to you, Dr. McLaughlin, is regarding the difference between hip resurfacing and hip replacement. If you can just kind of give an overview on a comparison on those two.
Yeah. So hip resurfacing is very similar on the socket portion or the cup side. They're a little bit different, but the main difference comes on the femoral side. Instead of removing the femoral head and neck, which we do and we put that implant inside of that bone, a resurfacing is where we shave down the femoral head and put a cap on the femur. There's advantages. There's certain patients from an activity standpoint, an age standpoint, sizing component that fits. Other times it's not an appropriate surgery. Usually those surgery are reserved for a lot younger type patients, 30s, 40s, even very active, lower 50s types patients. But they're very different. They want to accomplish the same thing. There's benefits and risks to both of them, but it's really, to answer your question, on the femoral side of how we're fixating an implant to the bone.
Wonderful. Thank you. And now I'm going to ask Dr. Erossy, I have a question for you. So if somebody does, well, actually I'm going to pose this to both of you, but Dr. Erossy, I'll start with you. If someone does a partial knee replacement, does that mean that eventually they would need a full replacement?
No. No, in fact, I mean, I would say the majority of patients do not. In, the right patient candidate for the surgery. If it's, if you're performing it in the right patient and you're doing the right surgery for them in terms of, technically executing the partial knee replacement, again, I do find a benefit to robotics in this, with partial knees as well. Being super accurate with the balance of the knee and the implant position, I think is super important for the longevity of the implant, as well as not putting too much stress on the other compartments of the knee, which, potentially could contribute to developing that some years down the line. The majority of patients and well-selected candidates who've had a great surgery do not need more surgery down the line now.
Wonderful. And would that be the same then for hip as well?
Different types. Half of a hip replacement or a hemiarthroplasty is usually in the older population, lower demand after a hip fracture or they break the hip. Different type of scenario than an arthritic type patient.
Wonderful. Thank you. One of the other questions that we have is, I'm going to ask you, Dr. McLaughlin, as well, regarding osteoporosis in one side of the hip. And I know you touched upon this, but just if there would be any additional information to prevent that osteoporosis from getting worse.
Yeah, I think that having a diagnosis is important to start with, right? So sometimes patients will come to my office, and the way that I'll see that is sometimes their history, repeated fractures at even a younger age or something like that, a fragility type fracture, but also, visualizing or looking at the x-ray can sometimes get us down the pathway of needing a diagnosis. That's the first step. Second is optimizing from a medicine standpoint. What can we do from supplements? Is it calcium? Is it vitamin D? Or is it something that's a little bit more aggressive in terms of bone remodeling type medication, and getting that patient to the appropriate physician or team that can make that diagnosis, but also follow them for those treatments. I think that's really important.
Wonderful. Thank you. Dr. Erossy, we have a question here. I know that Dr. McLaughlin had touched upon diabetes in hip surgery. So I do want to ask you the same question. If somebody is diabetic, is a knee replacement an option for them? And if so, is there any kind of special considerations, especially in regards to infection?
Yeah, definitely. So I think, again, it kind of goes back to patient optimization and safety for the surgery. So, diabetes, either type 1 or type 2, is an independent risk factor for complications after surgery, particularly prosthetic joint infections, wound healing problems, that kind of thing. I think in general, where we are with hip and knee replacement, we're really good at addressing, issues with the implants and different approaches and robotics, and we're getting real fancy with all this kind of stuff. Where we have yet to really push the needle and make significant strides is in infection and treating prosthetic joint infections. I think they're all, I think most of us would agree they're essentially the bane of our existence, and getting a, infection deep in a joint after a total hip or knee replacement is a disaster. They're very difficult to treat. More surgery. Sometimes you're ripping implants out and doing these crazy antibiotic spacers. You're getting antibiotics through a line in your arm, for a period of time. Sometimes it's more surgery after that. So, I think here it's like prevention is the best medicine, and, trying to manage these infections is very difficult. And the best way to manage it is to not get one. So getting your diabetes as optimally controlled as possible in whatever way that means. And of course, that's different for every patient. We monitor your blood sugar levels and your hemoglobin A1C labs, and, the primary care doctors and endocrinologists are, really key for that. And, dietary modifications, I think, can be huge, focusing on a high protein diet, just cutting out a lot of the processed carbohydrate stuff and all that kind of sugary stuff can really help. And, really getting you optimized before surgery. So, and that can take time, which is frustrating for patients when, man, doc, my knee's killing me. And, and we have to tell them that, like, look, you're not safe for surgery right now. It's just too much of a risk for you. We can make you a lot worse with the surgery too. So taking the time, investing in your health, before undergoing something like this, I think is huge.
Wonderful. Thank you so much. The next question I'm going to pose to both of you as well, because I'm going to ask a hip and then a knee topic. So Dr. McLaughlin, I'm going to ask you, are there any updates on hip bursitis treatments?
Yeah, it's a great question. So hip bursitis, what is bursitis? Is bursus. We have them, common areas that we have them are the end of our elbows, our knees, but our most bony prominence on the outside of our hip has a bursa, or a fluid-filled sac, and that becomes irritated for a variety of different reasons. But one of the things is, so that fluid-filled sac is meant to allow for gliding of soft tissue over that area of bone. And so between that bone, the fluid-filled sac, and then the outside of it is a band of tissue called our IT band, or iliotibial band. So that band becomes tight for a variety of different reasons. If it's injury, if it's more sedentary, if it's something else that is causing us to walk differently, maybe like a recovery from something, whatever it is, it's that tight band of tissue that's compressing that fluid-filled sac and irritating it. So a lot of times what we start with is physical therapy, mainly from a stretching standpoint. How can we optimize that tight band of tissue? How can we loosen it up so it's not putting as much pressure on that fluid-filled sac? Other times, anti-inflammatory, a short course regimen. Sometimes we go with injections to decrease the inflammation. But all of those things, the important part of that is a dedicated stretching routine is really important to put less pressure on that fluid-filled sac.
Wonderful. And would that be similar, Dr. Erossy, in knee bursitis?
Yeah, I think so. A lot of what we see are the three tendons that sort of attach on that inside medial part of the top of the tibia bone. The pes tendons, or pes bursitis, PES, pes, those tendons can get really irritated, just from different conditions and issues from the knee. It can also happen after knee replacement. And so, stretching, ice, anti-inflammatory routine, particularly to address that, can be really helpful.
Wonderful. My next question could potentially be for both of you. And I thought that this was a really great question upon submission for registration. And that was, can hip pain also affect the knee? And if so, how do you distinguish between what may actually be the root of that pain?
Yeah, great question. So yeah, hip pain can definitely present itself as radiating pain down the femur bone. So hip pain, we saw a lot of that femoral head, and as Dr. Erossy showed you that knee. And so I showed you the top of the femur bone, and his presentation showed you the bottom. So sometimes patients can get symptoms. Usually it starts in the hip, or it can be, doesn't have to be mainly, but it affects the hip in some way, but it radiates down the femur. And sometimes patients will come in with the main complaint is, if they're grabbing say the distal third of their femoral bone. Well, we take an x-ray of the knee looks good, minimal arthritis or whatnot, and it's really that hip that's arthritic. And so that's a good question. You can definitely get symptoms from the hip that travel down the leg.
Wonderful. Thank you. Now, one of the questions that we received that I think would be helpful for about half of our audience is in regards to hormones, perimenopause, menopausal, these kind of concerns. Is there an effect on any kind of hormonal issues on, let's say, specifically the knee pain in regards to pain or cartilage? Do those coincide, or is there any kind of correlation between the two? Sorry, Dr. Erossy.
Sorry. Yeah, I mean, I think certainly from a perimenopausal standpoint, and as female patients age and enter into this time, all of these hormonal fluctuations that do affect the bones in a very major way, as a causative phenomenon or process that can cause osteoporosis, leading to the weakening of bones as they age. That's certainly a factor, definitely. Yeah.
Okay, great, thank you. I did want to touch upon, I know you both discussed injections, and this is a question that comes up often, and we want to just kind of touch upon it. So I'm going to ask you both. In regards to the various injections, let's just start with knee injections. Dr. Erossy, is there like a limit on how many knee injections someone could get? And if so, what would be that limit?
So I think it, probably varies per the patient and the surgeon a little bit. Typically we don't like to just keep doing them over and over and over and over for years and years and years. Some people, that's all they want, and they're happy with doing that, and they find that those injections are efficacious. The knee is typically probably, well, they're easier to do, first of all, and I think people get more of a benefit to them than compared to the hip. I think there's some more relatively recent literature that shows that cortisone injections to the hip, or at least multiple of them, can accelerate some damage and actually cause a little bit more damage over time to the joint. So I'm not a huge proponent of cortisone injections to the hip. Now they can be really helpful, and I certainly use them, but maybe sparingly, and certainly as Dr. McLaughlin talked about from a diagnostic standpoint, I think that can be really huge. And if there's a patient with spine pathology coexisting with hip pathology and arthritis, then that can be a really powerful tool. Knees, I think it's you try a couple and see how it goes. You try to space them apart, certainly no closer than every 3 months, if not longer. And then you kind of see how it goes. If the cortisone stops working, you can try a hyaluronic acid or a gel injection after that.
And then in regards to the hip, is it similar?
Yeah, just kind of echoing what's been said, is really how much relief is the patient getting, and how long are they getting that relief? That really guides that. And I agree. I don't like to inject the hip very much. 1, maybe 2 times. Knee is probably a little bit different, but repetitive injections of the hip, I think that you're going to be doing a little bit more damage than benefit.
Thank you. I'm going to ask, we have time for one more question, and I will pose it to both of you, and then we'll just start with you, Dr. McLaughlin, in regards to, is somebody eligible for a total hip replacement if they live alone?
Yeah, good question. This is patient education, preparing for surgery. So we created these videos that gives the patient a good idea. So you come into the office, right? We find that you need a hip replacement. We have these educational videos that you can watch to say, what before can I do? What can I expect during the surgery itself? And then specifically afterwards, how can I prepare my house? How can I limit the amount of stairs? How can I get an elevated toilet seat if that's necessary? How can I, move furniture, move rugs? All of those things. I definitely have patients that go home by themselves after surgery. I always like to have, if they can, somebody to help them for the first 1 to 2 weeks. It doesn't have to be a 24-hour scenario, a few times, or, close by for a phone call, something like that. But patients can get home by themselves. They just need to prepare a little bit more beforehand.
Wonderful. And I'm assuming that would ring true as well, Dr. Erossy, in regards to a knee replacement?
Yeah, absolutely. I think this is it's a safety thing. You have to be safe at home. You have to have, help if you need it. This is major surgery. You cannot fall afterwards, right? Terrible things happen when people fall after this these kinds of operations, and it's just a safety thing. So, knowing that this is going to be an issue ahead of time, preparing, as we kind of said, is key.
Wonderful. Thank you both so very much. I want to thank both of you for your very thoughtful presentations, as well as for your time today, and of course your time with myself in answering some of these questions. A little bit for our audience on what to watch for next. Just a quick note that this recording will be available probably within the next 24 hours, and you can share with loved ones or rewatch if there was an area that you wanted to readdress or learn a little bit more about. So please watch for an email from the Cleveland Clinic with this recording, as well as some of these resources as well. And in addition, prior to us closing this webinar, we wanted to make sure that you can get those pieces of information from the handout section. So if you want to download our waiting room slides, that's an excellent resource for anything that you might need moving forward from the Cleveland Clinic. And of course, if you are in need of an appointment, we have in the chat function, there is an available offer for you where you can submit your information, and somebody from our offices will give you a call if you are looking for an appointment. We do want to thank you all again so much for tuning in. As always, we wouldn't be able to do these without our wonderful and thoughtful audience. So thank you so very much. And I hope everybody has a wonderful rest of the day.